Okay, so Kaylee was on the call and she had asked about fibromyalgia and the use of opioids and also marijuana with regard to that. So back to the discussion, fibromyalgia is an altered pain curve or a increased or reduced tolerance to pain. And the last thing you want to do is give someone that causes more pain when they take more of the medication. So Kaylee, if you were my patient, I'd be trying to get you off of the hydrocodone a little bit at a time, and then looking to some of the latest and greatest treatments, which are some of the medications that we learned from Cymbalta. Cymbalta was an antidepressant medication that came out, and we found that it helped people's pain more than it created, it helped them with their depression. And from that have come other medications like Savella and other things that actually work at the higher in the brainstem to modify what we call ascending pain fibers or ascending signals to the brain for pain. And then there might be some other relaxation techniques and other things of that nature. As far as marijuana use, Kaylee, that would be an experimental thing, but certainly you would fit the indication for getting a marijuana card for having chronic pain, and it doesn't really matter what that pain is. You have chronic pain, and if you've tried marijuana and it does help you, then that would certainly be an indication to continue to use that. But that's the brief skinny on fibromyalgia. It is a very chronic condition. It used to be what they call a wastebasket diagnosis, meaning he would come in with pain and we would do a bunch of testing looking for any type of rheumatologic disorders or autoimmune disorders. They would come up negative. You would have pain in the big muscle groups in your thighs and in your neck, things of that nature. Massage therapy can help, relaxation techniques, anything that you can do, and understanding why you have this unfortunate lower tolerance to pain may help to alleviate some of your suffering that you may be having. So hopefully that helps you there briefly. Getting back to COPD and chronic obstructive pulmonary disease. I don't know, is Kaylee still on the phone? Does she have any other questions? Or
I had one other question.
Okay.
And it's just really quick. I was just wondering if you knew anything about neurofibromatosis.
Neurofibromatosis?
Yes.
Yeah. Elephant's man disease. Basically, neurofibromatosis is a genetically inherited disorder associated with neurofibromas on the nerve system, where they basically get a conglomeration of scar tissue and outgrowths where you have nerves and sensory nerves, a quite disfiguring disease. That is, again, I think autosomal dominant, or maybe recessive, but it's very rare. Cafe au lait spots, which are these spots on your skin where it looks like someone spilled some coffee. If you have greater than 5 in a certain size distribution, you might be a carrier for the genetic trait. Other than that, that's about all I really know about the issue. I don't know if that answers your question.
I was just wondering, because I know there's a doctor, my husband has it, and there's a doctor that has him on pain medication like oxycodone and morphine, and so he's just trying to figure out ways, because he doesn't like being so much on the pain medication, but trying to figure out if there's other ways of trying to get help, or if marijuana would be a good use for that, or what?
Well, I think marijuana could probably have a use in a lot of different pain symptoms. This is one of those things where, again, the government is never going to do any controlled studies on the use of that particular substance. So if he has chronic pain and is on a chronic opioid, then he becomes a patient able to take marijuana, or should be able to get a marijuana card based on that. Meaning, if you're taking chronic pain medications and you have a condition that warrants the use of hydrocodone or a long-term morphine, then that qualifies you to have enough pain to need to get a marijuana card.
Okay.
At least that's the way it would work in my book.
Okay. I appreciate your help so much.
Well, you're welcome, Katie. Thanks for the call. Very good questions.
Thank you.
And of course, neurofibromatosis is a very painful disease because it does involve the nervous system on the superficial nerves and would warrant that. And probably along with fibromyalgia, blocking the pain fibers as they go up. And that's why I like methadone, because it blocks all forms of pain. It's basically an umbrella. And pain is like an electrical circuit. It can go up this way, and if you use opioids, you're just going to block it in the reticular activating system, but pain can reroute itself through another ascending fiber and reach the cortex of your brain where you perceive the pain. Remember what I said earlier about pain as being one of those things that we kind of learn. Little babies, if you've ever watched them fall and hurt themselves, they don't necessarily get up and cry. That's a learned response. And all of a sudden their parents run to them and they're all excited. And I think they cry because they get scared more than they're in pain. So in some respects, somewhat of pain is a learned response. You can actually hit yourself and it doesn't really cause you that much pain, but it's amazing. Phantom pain, look at phantom pain. When you amputate someone's leg, you still have the sensation of pain remembered in your brain. So there's a lot we don't understand and maybe may never understand, but some pain is a good thing, meaning it lets you know that something is not in check and not in right. And obviously when pain gets out of line, such as in Kaylee's case with fibromyalgia, it becomes disfiguring and well as uncomfortable. And opioids have their bad side too, which is they do relieve pain, but then they create more pain when the pain medication wears off, and that's what you have to be careful about in using it in chronic pain conditions. And that's why hydrocodone is not a good long-term pain medication. It's a 4-hour medication, so it wears off and leaves you wanting more medication. So anyway, back to chronic obstructive pulmonary disease. It is a chronic condition associated with outflow of the air, meaning same thing as if you could take in let's say you're taking a balloon and you blow up a balloon at the end of a straw and you let out 50% of the air, and then you basically tend to only let out 50%, and then you take the next 100%, and now you have 150%, but you let out 50%, now you're down to 75, and you keep expanding that balloon because you can't get that air out. And that is basically the condition of chronic obstructive pulmonary disease, usually caused by mucus plugging and scarring of the small airway. And behind the small airway is the alveoli of the lung, which is these grape-like structures where you have this huge surface area for exchange of oxygen as well as the expelling of CO2 and the introduction of oxygen into those areas. Mucus, the stuff that we make in our lungs that we cough up, is basically the stuff that traps dust and noxious substances as they are inhaled into your lungs, meaning if you didn't have a mucus clearing mechanism in your lung, you basically would fill up with dust. So what ends up happening is as that mucus is made, when you smoke or you do something, you actually kill the hair cells in the lung that actually beat the mucus up out of the lung as it traps the air, the noxious substances, and moves over into your swallowing pipe, and you just swallow the mucus. When you change that lung tissue in response to the irritation from the smoke, you get rid of those ciliary hairs, but you don't get rid of the mucus cells. So you create this mucus, and that's why people develop a smoker's cough, because they can't clear the mucus any other way. So I know we have Becky on the line, so hang on a second, Becky, but as you inhale, you open your lung and you have a mound of mucus, and so the air travels over the mucus, and then as you exhale, it collapses against the mucus plug. So the air gets trapped behind it, and that's basically the phenomenon of chronic obstructive pulmonary disease. You eventually blow up your lungs in a very small area. Becky, are you there?
Yes, I am.
Okay.
I'm here. Hello?
I'm here.
Okay, I have a question. I have fibromyalgia and systemic lupus and glaucoma. Right now, my systemic lupus is kicking up where I have a rash from about my shoulders down. Is that normal?
Okay, I'm having a hard time hearing. Can you speak a little louder? Maybe turn off your TV so there's no echo.
The TV is off.
Okay, so speak up a little louder.
Okay, now is it normal for systemic lupus and to have, what do you call it, a rash from your neck down close to your toes?
A rash from the neck down from to your toes?
Yeah. It's like a psoriasis, but red spots at the same time.
No, that's not normal, and any rash is not normal, and I don't know. It sounds like an exfoliative dermatitis of some type based on a total body coverage, and that could be anything from allergic reaction to the medications or the Stevens-Johnson reaction, which is a very severe allergic reaction, or worst case, it's unrelated to anything, and exfoliative dermatitis can represent a diffuse cancer in your body. And I don't mean to scare you, but probably a good idea for you to get that checked out.
Yeah, I know that my palms and my feet will peel and everything, and then when it dries up, it looks just like psoriasis.
Well, I mean, you could have psoriasis, but you know, those are things that are very hard to diagnose over the phone. So my best advice to you is get into your primary care or a dermatologist and let them take a look at that.
Okay, yeah, I'm trying to get into a pharmacist or a physician. I actually tried to get with you, and they said no opening until April.
Yeah.
But I am trying to get in as soon as possible. They gave me prednisone, and it did help, but it was only for 5 days.
Well, I think there's a couple dermatologists in town, Tahiri and Gunther's office, and then or Las Vegas and Cancer. You may need to go down to Vegas, but I'm sorry to cut you off, Becky, but we're ready to close the show. But thank you for calling, and please see somebody ASAP to get that thing taken care of. And I'm Dr. Reiner signing off. We'll hopefully see you here next Monday night. I'll continue COPD and the childhood diseases. Thank you for tuning in.